Yeah, yeah, a long, and you still are.
Good morning, everyone. Oh God, come on. The Liberty ticker tape parade today. Good morning, everybody. Great. I'm Rose Pierre-Louis, and I'm the Executive Director of the McSilver Institute, one of the co-sponsors of today's legislative breakfast, and welcome to NYU. Many thanks to all of you for joining us for this important dialogue on city and state legislative priorities to address the ongoing crisis of Black maternal health. First, let me begin by acknowledging today's sponsors. The Greater New York chapter of the Links Incorporated, the New York City Mayor's Office of Equity and Racial Justice, the Institute for Excellence in Health Equity at NYU Langone Health, the National Action Network, the New York Urban League, the NYU Myers College of Nursing, One Brooklyn Health, the New York City Commission on Gender Equity, NYC Her Future, the NYU Silver School of Social Work, and the Columbia University School of Social Work. Please give a round for all of our sponsors. Round of applause. So as co-sponsors, we represent health institutions, higher education, government, civil rights, and community-based organizations that have come together out of our shared interest and concern about Black maternal health. We seek to work in collaboration with legislators and policymakers and the community to arrive at solutions together as a city and state. On behalf of the sponsors of this forum, I'm not crying, it's just allergies today. On behalf of all of our sponsors, we are truly honored to have so many elected officials and policymakers in government who have prioritized Black maternal health. Within this group of public officials, we have an extraordinary cadre of women who are leaders in this city and state. We have a city council, which for the first time in its history, is women and people of color majority. And you can clap for that. And joining us today, we have the trailblazing and the first Black woman to serve as the majority leader of the New York State Senate. We have the first Black woman to serve as the Speaker of the New York City Council. We have commissioners, chairs of key legislative committees, and public sector allies who are our allies in this work. This morning, we have it all. Madam Majority Leader, Madam Speaker, Madam Chair, Madam Commissioner. And for me, this is my own personal PSA. I hope next Tuesday that we have Madam President joining us in this work. Not to be political at NYU's time, but today you're going to hear from health professionals who will provide some background on what is happening in terms of Black maternal health, and thereafter we're really excited to also have elected officials and policymakers to speak about legislative progress in this area and where we need to go in terms of policy. And then we'll hear from all of you in the audience during our question and answer session. Before we start, a couple of housekeeping matters. I see a lot of people have their phones out, want to take pictures, want to record. Please know that we have 2 photographers here, so we would ask that you turn your phones off, and we're also videoing these proceedings. So we ask that you not videotape or record these sessions. We'll be sure to get all the photos, the link to these proceedings when they are available. Also, in an effort to spend as much time on the topic, take a moment to scan the QR code that's on the screen. That will take you to a page that has all of the bios of all of our speakers, as well as information about related legislation on the city and state level, as well as community resources. And for sustainability purposes, we also didn't want to print out a whole bunch of stuff. So please check it out. Before we get started, A few weeks ago, we read about the tragic death of Bevlorin Garcia Barrios, a 24-year-old former track and field star who was admitted to the hospital and died after delivering her baby via C-section. We want to take the opportunity today to dedicate this event to Bevlorin and to those birthing people we have lost. And now, to lead off our program, we have a number of special guests who will provide opening remarks. Our first speaker is the Honorable Andrea Stewart-Cousins, who is the Majority Leader of the New York State Senate and has the distinction of being the longest-ranking serving member of the as Democratic Majority Leader in the New York State Senate's history. And she is the first woman and the first African-American woman to occupy this role. Please welcome Majority Leader Andrea Stewart-Cousins.
So good morning. Good. See, you perked them up, Rose. You know? So it is extraordinary to be here and to just lead off this conversation that we know is generations too late. And I say that because I lost my grandmother, my maternal grandmother, at childbirth. I never knew her. My mother didn't know her mother, but she played at her funeral when she was 4 years old. She'd lost her mom and her baby brother in childbirth. And I remember the conversation that she always had with me is that, you know, yes, I lost my mother in childbirth, and then there was nothing to be said, because it was almost understood. It was part of what happened. Now, my mom was born in the early part of, I think it was like 1917. And at that point, it happened so often that people just, tragically moved on without any discussion at all. It is amazing that we are in 2024 and still having conversations about women, certainly Black women, who are at higher risk of maternal mortality than almost everyone else. But there's a difference. The difference is all of us. The difference is the representation. And I think this is on full display here, not only with the partners that have come together to have this legislative breakfast, the consciousness of an NYU putting resources in making sure this happens, and the leadership of my colleagues in government on every level, who I know you'll be hearing from today, that we have the privilege of working with to address this problem. I am the leader of the Senate. I'm the first woman to lead any conference in New York State's history. And I'm proud and privileged to lead a conference that includes some of the speakers that you will hear today. I see Senator Summer Brooke, who has just arrived from Rochester, y'all. Came in from Rochester. She chairs my mental health committee. And again, something that was important when I became leader, because mental health was aggregated in everything else, substance abuse disorder, everything was lumped. But we understood the importance of creating a space so that the mental health would be its own category of interest. And what we've been able to do even around maternal health is making sure that there's these mental health screenings, that there's screenings for depression, so that we're not pretending that there aren't other implications in terms of maternal mortality and outcomes. You're also going to hear from Senator Leah Webb. Senator Webb is the chair of my Women's Issues Committee. Again, before I arrived on the scene, there was no committee that dealt with the issues facing women. And now there is a space where this conversation takes place. And I was just looking at some of the things that we did just this year: maternal health care and birthing standards work groups, maternal mortality data and informational materials, requiring maternal depression screenings for new moms. We have now permitted doulas in the operating rooms of maternal care facilities. The conversation about doulas was a very robust conversation because, again, you know, on a state level, people don't know what they don't know. And so when you're talking to someone who has never heard of a doula, doesn't know what it is, to get to a point where now not only we've raised the salary, but there is insurance coverage of doula, the conversation is different. The conversation is also different on local levels, because even where I am in the city of Yonkers, which is the third largest city in the state, we have community organizations such as Sister to Sister, and Cheryl Brandon, the executive director, is here. But I was able to connect them with our biggest hospital where birth happened. And because there was this interest in community, we were able to have the conversation. And now the conversation has become so robust that they are working with the Department of Health with birthing equity improvement programs. They are working directly with community, bringing partners in, and even pioneering a birthing team structure so that folks have an understanding of what is happening when. All of this is part of the collective effort to stop the conversations that only seem to have begun when people of note, such as Serena Williams, found herself in an inexplicable position, having everything that she should have, thinking that birthing is a natural thing, without the understanding of why her outcomes were so dubious. We, as a state, we as Black women, we as her allies, we understand that this is a moment where we can change the trajectory so that people like me who say I never met my grandmother because I lost her due to childbirth, there'll be an end to that. And women will get the services they need. They'll get them as they will understand. They'll be educated before they're pregnant and have the support system during the pregnancy and have the outcomes of beautiful, healthy babies. I want that not only, obviously, for Black women who are suffering disproportionately, but for all women. And as I said, representation matters. The fact that you are continuing to elect folks who represent you, and I didn't want to leave out Vicky Salages, our assemblywoman, who heads up the caucus. We are at the table. Please understand, you've got access. Panels like this give us information, and we have the ability, with the education and the inspiration of each and every one of you, to continue to improve lives. Do not underestimate your power. Do not ever underestimate your power. We know that we have been able to move mountains. We will continue to do so, but do not get weary, do not give up, and let us continue to make the future brighter. Thank you so much.
Thank you, Madam Majority Leader. Our next speaker is the Honorable Adrienne Adams, who is the Speaker of the New York City Council. Speaker Adams leads the most diverse and the first female majority council in New York City's history and is the first African American speaker. Please welcome Speaker Adams.
Good morning, everyone. It is so hard to follow. I called her my strong auntie in the struggle. How I love her, how I respect her, how I stand on her shoulders. Let's just applaud one more time for the Honorable Andrea Stewart Cousins. You know, she tells me, I've lived your life. And she has. I am so honored to stand before you this morning as the first Black woman to lead the most diverse women majority city council in the history of the city of New York. And it's so great to see. And I'm going to blot my eyes too, Rose, because these allergies are crazy. I keep saying Flonase laughs at this. But I apologize because it's quite annoying, and I know sometimes it's distracting. People do think that those of us with chronic allergies are crying. No. It is wonderful to see you, Rose, and stand in the space with you and your spirit of leadership. It's great to see. We've known each other for a very long time, actually. I also acknowledge all of my amazing colleagues who are here in government, and I'm great to see you always. And be in your company today. You know, we all have stories. And it's in spaces like these where we feel the most freedom to share them. Our majority leader just expressed a story about her maternal grandmother. It is the same story that Deputy Mayor Ann Williams Isom told a few weeks ago in another space that we were in speaking about this subject. It is amazing to me how these stories are out there. They are often pushed on the back burner, but we're gonna move this story to the front burner in a space where it deserves to be heard and seen and felt, because the death has to stop. There are solutions out there, and we have been dealing in silos for too long where the solutions lie. But we are going to bring those solutions to the forefront and conquer death. As a society, we accept maternal mortality as an unfortunate casualty, when in fact, a majority of deaths could have been prevented with appropriate care and attention. When you look at the severe racial disparities in cases of maternal mortality, it becomes clear that this is an urgent public health emergency. These deaths are not accidents. They are a disturbing pattern of injustice. Across the nation, Black women and others who can become pregnant disproportionately suffer preventative, life-threatening complications during pregnancy and childbirth that too often cost them their lives. Here in New York City, Black New Yorkers are 6 times more likely to die of pregnancy-related causes compared to our white counterparts. Black New Yorkers and other people of color are more likely to have their pain and their symptoms dismissed by medical professionals, leading to delayed diagnoses and insufficient care. And I said, we all have stories. I have a story. You see, my due date was January 14th, but I was born on December 9th. And so when my mother went to what was then called Elmhurst General back in the day, for about the third or fourth time, they thought again, you know, she's really not in labor. They didn't believe her. You know, my dad was at work and my mother took a taxi, again, full of me, and headed to Elmhurst General, where they put her in a gurney, in a room, in a corner. And they said, it'll be okay. It'll be okay. Well, shortly thereafter, my mother gave birth to me alone in a gurney, in a corner, in the back of a room. So I stand here a living miracle, still as I think about it, it's unfathomable to me because my mother would tell this story and she'd just say it so cavalierly. You know, you just, hey, you know, you wanted to be here sooner. They didn't believe that you wanted to be here sooner, but, you know, there we were, you know, attached through the lifeblood of the umbilical cord, attached, and then my mother yelled, "Nurse, nurse, the baby's here." They ran into the room, hysterical, when they saw me, Jen. There, attached to my mother, alone, in the back on a gurney by herself. You see, we black women are supposed to be the strong ones. We're supposed to be the ones that can take it. We are the ones that go into the hospital with life-threatening headaches and are given a Tylenol or two and told to go home and then are dead the next day. We are supposed to be the ones to hold that up, because our intestinal fortitude and the things that brought us here give us that strength. But to some, it's taken a whole different turn and twist when it comes to the vitality of our health care. We are human and we hurt. And we are dying in our homes and in our hospitals for something that should be the most natural thing to happen to most of us, and that is to give life. And so our job, I'm going back on script now, I'm sorry, I went off. As a women majority city council, our body is dedicated to this cause because we're made up of mothers, grandmothers, and those supporting their partners through pregnancy. This is deeply personal for us as people who are intimately familiar with the challenges of maternal health in our city, and as leaders who are determined to give this issue the scrutiny and attention it deserves. In 2022, we passed a historic 11-bill package of legislation to begin to address disparities in maternal health, mortality, and morbidity. Through this effort, we established a program through the Department of Health and Mental Health to train and provide doula services in marginalized neighborhoods throughout all 5 boroughs at no cost. Last month, we passed a package of bills that address the mental health challenges faced by parents and those who give birth to children. These efforts include providing support for individuals during postpartum, a particularly challenging period for mothers and their health. We're calling it the 4th trimester. We will continue to pass laws and make policy changes and investments, but there are limitations to legislative and policy solutions. Meaningful, systemic changes will require a cultural shift and harnessing of our collective political will. That's why a few weeks ago, I delivered an emergency address announcing my intention to convene stakeholders to confront the maternal health crisis with action and call it what it actually is, a public health emergency. And in these weeks thereafter, I've received so many calls, gratefully, from stakeholders across industries and organizations and government, eager to work together towards solutions. And now it's up to us, including all of us here in this room, to harness this energy to secure change. We cannot allow this moment to pass us by. There are many issues that deserve our focus, and this work must be guided by experts who can lead us to take concrete actions to achieve maternal health equity. Addressing these long-standing inequities will require sustained focus and ongoing action. Every preventable death continues to raise alarms on long-standing inequities and act as a grave reminder of the urgency of the work ahead. Together, we have to not only listen to our stories, but we have to act on them, and we have to move forward so that we can prevent other stories like ours from moving forward. No one should die from preventable causes. No one. We owe it to our mothers and everyone who can become pregnant. We owe it to ourselves. We owe it to our history. We owe it to the lifeblood that lives within all of us. And so together, we rise and we live. Thank you.
Thank you so much, Madam Speaker. Our next guest is Sadea Sherman, who's New York City's Chief Equity Officer and Commissioner. Commissioner Sherman brings nearly 2 decades of equity-focused community and economic development experience to this role. Please welcome Commissioner Sadea Sherman.
Thank you. I have to say, following Majority Leader Stewart Cousins and Speaker Adams is not easy, but I'm so inspired, and thank you. Thank you for all that you do for our city and for our state. I'm so glad to be here today to discuss such an important topic. I want to just first express my deep gratitude for all the partners who have come together to make today's possible, particularly Rose. Thank you so much for your leadership and for the work of the McSilver Institute. As New York City's first Chief Equity Officer, I have the privilege and really the honor of leading an office that's focused on racial equity and justice for New York City. On a day-to-day basis, we're focused on tackling the deep-rooted questions of equity, of justice, of structural reform. And few issues encapsulate these challenges more urgently than Black maternal health. What we know is stark. We know that Black mothers continue to face alarming and disproportionate health outcomes by race, irrespective of their socioeconomic status, right? We know that these disparities are not accidental. They are the legacy of centuries of medical racism embedded in our nation's history. We know that within our healthcare system, patients of color frequently experience bias, and providers often lack the training they need to provide culturally competent care. We know that too often Black patients, and I can experience this myself, are left to advocate for their own survival in spaces that should be prioritizing their well-being. And we know that all of this is unfolding against the backdrop of a political climate where even basic health care, like abortion care, are up for debate. And so addressing Black maternal mortality is without a question a systems issue. It will take the collective action of leaders in this room and many others who are not in this room to come together to figure out how we dismantle these structures and build something that can create a brighter future for all. Earlier this year, our office was proud to launch NYC Her Future, a new companion office to the Young Men's Initiative. NYC Her Future has hit the ground running, focused on doula training, STEAM training for young women and girls, and they are steadfast on their mission to uplift and empower young women and girls of color across our city. Our office is also home to the New York City Commission on Gender Equity, which for nearly 50 years has been focused on research and policies that address disparities that we see across genders. Together, our team is committed to advancing health equity and reproductive justice for all. We are excited to contribute to this important conversation today, but even more importantly, we're eager to listen and to learn and to hear from our esteemed panelists and everyone in the room. Every parent, every future parent in our city and in our country should have the support that they need to thrive. And so we know that this is not our first conversation. We know it won't be our last, but I'm certainly encouraged by the leadership we have, the progress that we've made, and the progress that we will continue to make if we build together. Thank you, and let's make the most of today's discussions.
Thank you so much, Commissioner. Our final speaker is Denora Gatachew, someone who I know very well, who is the president of the Greater New York chapter of the Links Incorporated, which I'm very proud to be a member of. And for 75 years, the Greater New York chapter of the Links has provided transformative programming for the Black community here in New York City. The Greater New York chapter of the Links and the Links Incorporated, our national organization, have identified Black maternal health as a national program priority for all of its 299 chapters across the country. Please welcome Denora Gatachew.
Good morning, everyone. I feel like it's set in, right? Like we're all wide awake now, the coffee's kicked in. As Rose noted, I'm Denora Gatachew. I am the president of the Greater New York chapter of the Links Incorporated. I represent over 60 Black women in our chapter, but I stand alongside 17,000 Black women who around the country, as Rose shared, have committed to putting a stake in the ground to eradicate Black maternal mortality. We really are committed to doing our part to ensuring the survival and the thriving of the African American community using all of the tools in our toolbox. Thank you for joining us at today's important and long overdue but solutions-oriented discussion. It is important that we stop talking about this issue and then putting it aside, but actually do something about it. Thank you to Rose Pierre-Louis and the McSilver Institute and our other co-sponsors for making today's event possible. I applaud the members of my chapter, including Rose, Lenara, Dominique Sharpton, and Ebony Williams for their vision, their passion, and their hard work to bring today's event to life. Thank you to our elected officials, including Senate Majority Leader Andrea Stewart-Cousins, who I've had the pleasure of serving for in many capacities, and Speaker Adrienne Adams for coming to the table today to prioritize this important conversation to address what we now have heard is a public health crisis and is a critical emergency for our communities. I applaud you for the efforts that you've already undertaken and know that the Links look forward to working alongside you as we address solutions going forward. The reality is that we are facing a maternal health crisis, and that is plaguing Black women in particular. How is it possible that in the most developed nation in the world, and in the most developed city in our world, that almost every woman in this room could probably tell you a story similar to the ones we've already heard, similar to the ones that I could share as a mother of three, about how we were neglected, mistrusted, and treated poorly in our labor and delivery rooms and in the care that came after that. We have to address this dire disparity of facing our community. We have to make sure that Black women's lives are not at risk in a moment when they should be protected, uplifted, and celebrated, the moment of giving birth. It is heart-wrenching and unacceptable that no matter where we live, no matter our education or our socioeconomic status, that our Black mothers have to be neglected, mistreated, or receive less than quality care. It is important that we do our part every day to ensure that Black women are seen, that they know they are worthy of quality care, and that their lives actually matter. It is well past time that we do something more than just talk about addressing this, but actually take the substantive steps necessary to care for ourselves, for our Black mothers, and for our community. As Rose noted, the Links Incorporated has put a stake in the ground, and we are willing to put our collective strength, the power of the 17,000 Black women that are members of this illustrious organization, to work to address not the root cause only, but ensure that we eradicate this issue today and going forward. So I look forward to the conversations that you will hear today. I look forward to working with the partners who've joined us as a part of this event to really move forward comprehensive and timely solutions. Thank you, and I look forward to the dialogue.
Thank you so much. So at this time, I'd love to acknowledge some of the special guests in the audience. So we have Dr. Melissa D. Begg, who is the Dean and professor at the Columbia School of Social Work. Thank you so much for being here. We also have Commissioner Christina Curry of the Mayor's Office for People with Disabilities. Thank you so much, Commissioner, for being here. And I know at some point that Senator Jabari Brisport will be here as well, so please give him a round of applause. As well as Helena Grant, who is the president of the New York State Midwives and co-chair of the Brooklyn Borough President's Maternal Health Task Force. Give them a big round of applause. So at this time, we're going to take a 5-minute break in order to get our first panel up on the stage and mic'd up. And again, please make sure to download the bios, resources, and legislation that we'll be referring to today during the conversation. Grab some coffee, connect with one another, network, and we'll see you in 5 minutes. Thank you so much. Equal Justice with Judge Ebony K. Williams, which is a nationally syndicated television show. Ebony also hosts the nightly news show, The Griot, with Ebony K. Williams. Ebony is also the executive producer and host of the NAACP Image Award-winning Holding Court with Ebony K. Williams, and she's also the author of the best-selling book, Bet on Black, the good news about being Black in America, which was released in 2023. I'll also say that Ebony is a member of the Greater New York chapter of the Lynx, and I could go on and on about Ebony's accomplishments, contributions, and just all of her great philanthropic work. But I think the most exciting news that I will share is that Ebony is a new mom. I mean, she looks incredible. And she's the proud mother of a gorgeous baby girl. So please give a big round of applause for Ebony K. Williams.
God, I love Rose so much. And I know that is a shared sentiment in this powerful and loving room. So Rose, thank you so much for that. And I do want to share with this audience that my sweet baby girl's name is Liberty. And I'm not saying that we set the precedent for liberties being championed. Well, I'm not saying we didn't. No, just kidding. Thank you. And it does me such goodwill to be with you all today. And thank you so much to the leadership and to NYU and all of our co-sponsors. I also want to acknowledge my fellow commissioners here with us today. And I proudly also show up in this space in my capacity as a member of the Gender Equity Commission here for the City of New York as well. Allow me to introduce each one of these esteemed panels. And just so you guys know the context here, we're having two panel discussions. The first is laying really a foundational context as it relates to the healthcare component, the clinical piece of this work. And then, of course, we will have our legislative panel to follow, right? So I want to start by introducing these phenomenal medical leaders. First with Dr. Leslie A. Hayes. Dr. Hayes is Deputy Commissioner of the Division of Family and Child Health for New York City's Department of Health. Dr. Sasha James Contarelli, right here, Program Director of Nurse and Midwifery at NYU Rory Myers College of Nursing. Dr. Cyrus McCullough, here at the end, he is Chairman of Obstetrics and Gynecology at One Brooklyn Health, one of our co-sponsors, and Dr. Delise Robertson, Clinical Associate Professor at NYU Rory Myers College of Nursing, and Dr. Natasha J. Williams. She's Associate Professor in the Department of Population Health at NYU Langone Health Institute for Excellence in Health Equity. Please put your hands together for this esteemed medical panel. All right, y'all, I want to just level set here and give two really foundational points again for the context of this enormous but super important conversation. The first, y'all, is that we did not get to this state of medical and cultural emergency with just one thing being wrong. So it stands to reason that there's not going to be one solution, right? We're going to hear a multitude of systemic and potentially collaborative ways in which we can find solutions to create the eradication of what has become an absolute crisis in New York City and in New York State, and of course, nationally. Also, we are an open community, and we want to make sure that we are as plain spoken as possible with all these medical geniuses surrounding me up here. But we also don't want to oversimplify anything, right? You know, this, again, we want to honor the complexity of this, the nuance. So you're going to hear some statistics, you're going to hear numbers, you're going to hear data points. Just try to hold the space for the fact that there could be a lot of different ways in which that has come about. These things evolve over time, but use them as foundational guidance, right? Can I get a commitment from everybody for that? Yes. Thank you guys. Thank y'all so much. All right, with that said, I want to get started. I think the kind of paramount statistic that centers what a lot of us understand to be the basis of this crisis, please help yourself, doctor, is the fact that by most counts, Black women are 6 times as likely to die in childbirth or postpartum as our white counterparts. I want to start with this, Dr. McCullough. I will start with you on this. When we hear that type of discrepancy, whether it's 6 times or 9 times or 4 times, what we know is it is unconscionably more often. The discrepancy is horrendous. Why does this discrepancy exist, and why does it persist?
Thank you. Thank you for that question. Good morning, everyone. It's a real distinct pleasure of mine to be here as part of this panel and to discuss this very important topic. In New York City and New York State, there are multiple reasons why women, and particularly black women, are dying at such high rate. Among the top causes in New York State and New York City are maternal mental health disorder, and this includes substance abuse. It also includes suicide. Cardiovascular disease, which includes dilated cardiomyopathy, peripartum cardiomyopathy. Hemorrhage is a big factor. Stroke, pulmonary embolism, those are huge causes of maternal mortality. Why black women are disproportionately being affected? One cannot hide the fact that there is systemic as well as institutional racism that puts up barriers to accessing prenatal care. Not just prenatal care, but preconceptional care, care before pregnancy. More than 75% of these deaths are preventable.
What was that statistic again, doctor?
More than 75%
More than
of these
75%.
deaths are preventable, especially patients with cardiac disease, patients who end up having hemorrhage during labor and delivery. There are warning signs that can be highlighted if moms are able to get into care early, and especially prenatal care on a regular basis with quality healthcare providers. We can stem a significant number of these maternal deaths. Another thing to keep in mind is more than 50% of maternal deaths occur after 7 days. And that's when most moms are out of the hospital, they're home. So engaging in community organizations or doulas or midwives, making sure that moms get back into care. More than 50% of our mothers are not returning for postpartum care. And that's a very important issue that we need to address. Providing Medicaid coverage for a year after delivery is one step in solving this problem, but that's only a beginning. And we're talking about just moms who are on Medicaid. What about the working poor who are not on Medicaid? What about those with insurance, basic coverage that are, you can't take off from work? Those moms are at risk, so we have to find ways of getting them back into care, during that period of time when they're most susceptible to some of these diseases, especially things like peripartum cardiomyopathy, or arrhythmias that can occur at any time during pregnancy or post-delivery. So it's very important that we have this continuum, that we engage our community health providers, or midwives, or doulas, as part of that community support to our moms.
Thank you. Thank you so much, Dr. McCullough. And we are absolutely going to touch in this conversation what it looks like to talk about that type of collaborative care with midwives and doulas and obstetricians and all of that. I just want to highlight some of the things that you just gave us here, talking about 75% of the deaths we see of black women as it relates to maternal care are preventable. I think that is just so palpable. Also, 50% of these deaths occurring postpartum, within 7 days, you're saying?
After 7
After
days.
7 days?
After 7 days.
My God, that's just something for all of us to think about. Okay, Dr. Hayes, I do want to tap into your expertise, particularly as it relates to community and the fact that a lot of these deaths are happening after the birth itself and when these women and birthing people are back into community. Can you tell us, in your capacity as Deputy Commissioner of our city's health department, what are you seeing citywide and borough-wide in terms of these experiences for birthing women?
So let me start by saying morning greetings to everyone. And I also wanted to say it is indeed an honor to be here with this esteemed panel and also all of you. So I am truly honored to be here this morning. I also wanted to say that, and I think you've heard already, that the New York City government is explicitly committed to reducing maternal mortality in New York City. And at the health department, that commitment is center for us because we include that as part of our goal to center racial equity into everything that we do within the health department. Our programming focuses on making sure we are bringing racial equity into all of our program initiatives. So I think we all know, or we may not know, that in New York City, there is the most highest rate of residential segregation and income inequality. And it's been stated pretty much several times already this morning that historic and current structural racism is significant, and it's even more significant in communities where our Black women live. So that limits their access to quality health care. It limits their access to good, healthy food choices. It limits their access to social services. It limits their access to being able to have a healthy life, which also impacts healthy outcomes in pregnancy. So at the health department, one of our goals is Healthy NYC, and that is to increase the life expectancy of all New Yorkers to the age of 83 by 2030. And included in that is the goal to reduce Black maternal mortality by 10% by 2030 as well. So once again, our programming is focused on that. And at the health department, you know, we are about health surveillance. And in 2018, and I think the speaker spoke about this as well as the majority leader, that these issues have been going on for years. And in 2018, the health department established the New York City Maternal Mortality Review Committee, MMRC, which is called for short. And the focus of this particular committee is to review every maternal death that occurs in New York City. Every maternal death that occurs in New York City. And they do a holistic review of all of the charts. There is, and other medical information, not just charts. Currently, there are about 46 members that sit on this MMRC, and they are a diverse group of individuals. We have midwives, we have doulas, we have CMOs, we have community-based organizations, OBGYN, chairs of departments. So the breadth of the diversity of the committee is important as they sit and they review all of these maternal deaths. And one of the one of the requirements for the committee is that they produce a 5-year report. And I smile because I see several MMRC committee members here in the audience. And it's important to elevate them because the work that they do sitting to review all of these maternal deaths is a toll on them as well, okay? So they're required to do a 5-year report as well as an annual report. And we just recently, through the health department, released our 5-year report that looked at data from 2016 to 2020. And I know that we're not getting in the weeds, but I will share some of that data with you. What they found was that between 2016 and 2020, there were 241 pregnancy-associated deaths that occurred in New York City. And of those 241 deaths, about 43.6% of them were among non-Hispanic, Black, non-Hispanic women and birthing people. And just as Dr. McCullough mentioned, they also found that up to close to 75% of those deaths were preventable. And if you drill it down a little bit more, because I know that there have been all different numbers thrown out, what was seen in that report also was that for Black, non-Hispanic women, they are 4 times more likely to die of a pregnancy-associated death, and they are 6 times more likely to die of a pregnancy-related death. And once again, I don't want to get in the weeds, but I think it's important to understand pregnancy-associated deaths means, for example, you could be pregnant and die in a motor vehicle accident. So that's pregnancy-associated. Wherein pregnancy-related is some sort of cause that is related to the pregnancy itself. So you come in with hypertension, pregnancy-induced hypertension, you have some complications due to that, and that is the cause of death. So as mentioned, 6 times more likely to die of a pregnancy-related death and 4 times more likely to die of a pregnancy-associated death. I just want to also emphasize that 9 times that we hear a lot about was really over a 20-year period of time. So that's one thing to take into consideration versus a 5-year report and the data that I'm sharing. And in the report, there were also recommendations that were developed to utilize as means of strategies to address the deaths that we saw within the report. And the recommendations, when we talk about community, what are we doing? These recommendations are broken down within communities, hospital systems, health departments, and they are a guide to what we need to do to address maternal mortality in New York City. And recently, a couple weeks ago, and the speaker spoke to that as well, we had an event at the New York Academy of Medicine. We convened close to 400 stakeholders to look at how do we move these recommendations from on a piece of paper to action. It was called Ending Maternal Mortality in New York City, the Blueprint. And we were very happy with the response that we got from over 400 people or close to 400 people being there, with an opportunity to have them work in groups to come up with solutions or plans on how we're going to take these recommendations from being in a report to making them actionable. So there's a lot of work that we are doing within the health department to address maternal mortality in New York City, and that is why the event that we had was called just that, ending, not preventing, Ending Maternal Mortality in New York City, the blueprint. And that is based on our 5-year report that came out on September 25th. And I would recommend that it is available. It is on the New York City Department of Health website. And please take an opportunity to look at it and see where we are trying to address this serious public health issue that we have here in New York City.
Thank you, Dr. Hayes. Yes, that was, of course, going to be my question. Is it accessible to the public? And the answer is yes. So please check that out on the Health Department's website. And the
Yes.
recommendations are there as well.
Yes.
Excellent, excellent, excellent. I do want to go to Dr. James Cantarelli here and ask you about, we teed it up. Oftentimes people think about the medical clinician piece in either I'll elect to use a midwife for my labor and delivery or an OBGYN, or maybe I'll use an OB and a doula, but not. What does a comprehensive integration perhaps of the midwife role, the doula role, and potentially the OBGYN look like in a modern birthing experience for a Black woman in New York?
So first, good morning, and thank you for having me here, and thank you for that question. I'm happy to be amongst so many colleagues and friends in this very comfortable space, and thank you for the question. So as midwives, and there are many in the room, we all know and we support for every woman, not just Black women in our state, in our city, to have a comprehensive team of an OBGYN, a midwife, a doula, the nurses, your community partners. So this person, this birthing person, is surrounded with love, is surrounded with family, is surrounded with medical professionals that can meet them where they are, provide them with the loving care that they deserve, have them transition from their home, their community, to wherever it is that they choose to birth, and then return back to the community in a seamless manner and address any of their needs that need to be addressed. That comprehensive group can also collaborate, have communication, and early identification of any of the issues that can arise, as we heard. Usually and typically, if there are issues that are going to arise, if they're not identified during the pregnancy process or the pre-pregnancy process, they will arise long after that person has left wherever they chose to birth. And so the commitment of the healthcare team to be in communication and seamless communication with the community partners is so essential. And so as my role as a program director at NYU, and I sit on the New York State Maternal Mortality Review Board, so I applaud the work and the numbers that were just put out, because unfortunately statewide, outside of New York City, those numbers look the same for Black women across the state. Most of our deaths are preventable. The majority of them are after people leave the hospital or the birthing center or wherever they birth. And so this is a collective effort, not only New York State, but New York City, but New York State. And our report also is accessible for New York State. But as a director and an educator, what I know, being a member of New York State's Maternal Mortality Review Board, is that I need to bring that back to the classroom. And I need to prepare the next generation of midwives to get out into the community, to understand the disparities that are occurring, not just for only our Black women, but for all women, to center Black women, center the Black experience, and for them to understand the need for a comprehensive and collaborative group of not only in-hospital, but community workers to address and eradicate this problem that we're seeing, the emergency, the crisis. So that's my role, and that's the importance of a comprehensive team. I'm so happy that we're speaking the same language up here across the board. So you're not going to really hear anything differently.
Yeah, that's
Yeah.
right. And Dr. James Cantarelli, also, we don't want to take anything for granted here, and this is a big question, but to, as simply as you can, distinguish between a doula, a midwife, and an OB, just so everybody understands that those things have unique postures in this process.
Okay, so I will start with a physician. So that's an obstetrician, gynecologist, a physician, and there's many different specialties in that in a physician. So a physician that chose to be an obstetrician, gynecologist, and then I will compare them to midwifery. An obstetrician, gynecologist, besides medical school and their residency, and if they choose to do a specialty, a subspecialty, and a fellowship, will then come out into practice. And they've had, in residency, also have had surgical residency and surgical training. For midwifery, for us, and those of us that choose to be nurses and then become midwives, so I'm a nurse midwife, there are also certified midwives in New York State. And the difference between the two is that as a certified midwife, they have a bachelor's degree in a science, and then they go into midwifery as a specialty. There are 4 programs across New York City. One's at NYU, one's at Downstate, one's at Stony Brook, and one's at Columbia. And there are master's program to begin with, except for Columbia that you have to terminate in a doctorate. And when in that, because we've had nursing as a foundation for some of us, we then go on to have our master's and a bachelor's degree in science. We have a foundation in science for the certified midwives, and go on to get our master's in midwifery. Midwifery is a 3-year intensive training of everything that most of what physicians learn, except for surgical residency. So we have clinical rotations embedded. It's 3 years nonstop. We don't take summers off. We don't have breaks. And you're trained alongside many of our physicians, other nurse practitioners, PAs, and then they come out and they're generalists, and we're experts in normal physiologic birth, primary care, intrapartum care, antepartum care, preconception care. And that's where we're experts in normal physiologic. So we work alongside our physicians that understand and are very well trained, and when there are emergencies, that we work together in order to give comprehensive care to a patient. And doulas many of them are our community supporters. So back in the day, before midwifery was eradicated in the United States and is on the rise again, thank God, because it was, when it started, was by enslaved folks in the United States, and then were told that they were not educated enough to care for their communities. On the rise again, thank God, is that doulas took over the part that we could not do anymore, which was the community involvement, that connection to the community, the support of the woman and the birthing person before their pregnancy, during their pregnancy, if they're wherever they choose to birth, and return them back to their community. So they're an important part of the team, because as midwives and as obstetrician gynecologists, sometimes we don't have, in this very insurance-driven world, and we are shortened for time, we don't have that time to sit with many of our patients, although we would love to. I'm sure there's nobody on this stage that would not love to spend an hour talking to each one of our patients, educating them, giving them resources, but we have time constraints. So doulas play an important part for us in that they have the time to spend with each patient. As midwives, what we do is we also work very closely with our doulas in order to ensure that the community piece is translated to the medical part of it. So that's, in a nutshell, what we do. Very
Fabulous.
short.
I know, very short. And that's why I said it was a big question, and you did a phenomenal job, doctor. Thank you so much. That was so helpful. Because I will say, I was going into my 2nd trimester pregnant as a advanced maternal age, formerly known as geriatric, fairly educated woman here, and I did not know the difference between a doula and a midwife. I thought I did. I did not. So I ended up having a fantastic doula in my birthing experience. Thank
I
you.
forgot to mention that midwives are certified, nationally certified. So we have to maintain certification as physicians do every, oh my goodness, every year. Every year with our lovely tests, we have to maintain our national certification and our education requirements. So once we graduate, we have to sit for a national board. We're certified, and then we're licensed in each state that we work in. We maintain that licensure, and we also maintain our national certification. Our programs are accredited nationally. Our programs and our national organizations work together, which means the American College of Nurse Midwives, along with the American College of Obstetricians and Gynecologists. So we work very closely hand in hand, and we have joint statements that are also available on the web.
In other words, they are credentialed. Okay? Anybody confused? They are credentialed. Amen. Thank you. Dr. Robertson, I want to ask you, in your capacity as a clinical professor, to talk about something that Dr. McCullough teed up when he first answered why such a large discrepancy of Black women dying so much more frequently than white women, and that was the mental health piece. So Dr. Robertson, please describe how significant, how critically important the correlation between the mental health piece of Black women and birthing people to our maternal outcomes.
Thank you for your question, Ebony. And I am so pleased to be here to be part of this conversation, especially with the interconnection of mental health and maternal mental health in this dialogue. So when we think about mental health, though, we often hear conversations about mental health being the problem, when really mental health is the solution. So mental health is the capacity to have emotional regulation, social well-being, and be able to manage all of our experiences in our lives without significant impairment. Now, we don't live our lives in a bubble. And so during pregnancy, there are the natural challenges that occur, the changes to the bodies of pregnant people. But for Black women and birthing people in particular, there are numerous disadvantages that we experience based on what our panelists have talked about. Systemic racism, the expectation to continue to function in all of the capacities that we have in work, in life, in parenting, in partnerships, in our responsibilities in communities. And so what that means is we are at a disadvantage because of all of those disparities. And unfortunately, despite the work that has been done to move us forward in addressing mental health in less stigmatizing ways, we as a community do not access mental health as robustly as we should. So what that means is, in this challenging experience of pregnancy that is natural occurring, we are not necessarily being proactive as a society in exploring what could be happening to Black women and pregnant birthing people during this time. And so what we're finding is that a lot of the data is prioritizing what happens after birth and some of the negative outcomes related to Black maternal health related to after giving birth. What we're not doing is understanding that 40% of Black women and birthing people are experiencing mental health conditions that are going untreated. So what that means is we are being very reactive in addressing things, and often when things are at its most severe. As newly appointed program director for the Psych Mental Health Nurse Practitioner Program, the goal is really to help us to understand how important it is to have integrated care. And what that means is partnering with our midwives and physician colleagues as psych mental health clinicians, who I am, in ensuring that access to care happens sooner. Access to mental health care looks like having conversations about what were the circumstances for conception. They're not always positive. What is your experience and knowledge about the changes that happen? What are some of the responsibilities that continue while pregnant? How are we addressing those needs as a community? How are we psychoeducating pregnant women and birthing people about what are to be expected? How are we addressing fear? Because of the history of mistreatment, the history of not being heard, and what that looks like in terms of anticipating the birthing process. How do we address anxiety? How do we talk about lifestyle changes? And so all of this is interconnected. And if we're not doing this proactively by creating opportunities for assessment throughout that perinatal period and beyond, then we're not doing justice. I am pleased to hear that the New York City government has established a task force for maternal mental health. That is hugely important because, again, that is a way of addressing things more proactively. Thank you.
No, thank you. And I will share on a personal note, when I told my OBGYN, who is a brilliant black woman here in the city of New York, that I was anticipating, for those unfamiliar with my story, I'm a single mom by choice, so I really opted into this thing with a lot of intention. And I said, I'm planning to conceive. The very first thing she said was not go get on prenatal vitamins, although she did eventually get to that. The first thing she said, doctor, was check in with your therapist. That was the first thing. And I was very surprised. And now, being more educated, I see why. I see she was being proactive in just the way in which you speak, and I feel very grateful. So thank you. Dr. Williams, you're up. All right. Dr. Williams, from your perspective, you are a professor right here at NYU in the Population Health Department. Talk to us a bit more specifically about, we're hearing community in all of these verticals, but you really, really center in it. Talk about how the community can play a role in reducing and eradicating these discrepancies. Specifically, maybe talk us through maybe the social media or the technology, the things that we kind of see show up in our day-to-day.
Okay, is this on?
No, it's okay.
Here.
There we go.
Thank you. So good morning, everyone. I'm very honored to be here on this panel. It's just been amazing listening so far to everything that's been shared. And I've sort of been trying to think about what is going to be different about what I'm going to share with you all. So first and foremost, I'm not a clinician. I am trained as a behavioral health research scientist, right? So really trying to understand individual behaviors. But we can't do that without understanding context, right? So understanding where people live, understanding the history of injustices that take place across this country. So I think, though, to even answer that question about community, first and foremost is that they have to be invited to the party, right? So we can't have a conversation about eradicating maternal mortality without community representation and what that looks like. And when we send that invitation, we need to follow up to better understand what would it take to get you there, right? So that's often missed in the conversation. So, and to the doulas and midwives, if you are here, please stand up because we really want to thank you.
Yes.
And yes, you as well, right? But it's just to acknowledge the service that goes with that, right? So there's a tremendous amount of responsibility that goes in that role to ensure the safety and protection of women and birthing people, right? So we talk a lot about some of the solutions, and we need to understand how are these solutions being accepted by systems, right? So a lot of my work, I'm trying to get past the observations and thinking about the problems. There are many. I have tons of research questions that I could pose, but it's really about taking what was shared, for example, by the Maternal Mortality Review Committee and get that into the places where people need it most. So we don't need to spend a lot of dollars on the research and the observations. although I'm cautious in saying that because I am thankful for the funding that I receive, right? But it is more about getting it into the places. So getting it into communities, getting it into hospitals as well, right? Where do people meet? Meeting people where they are and where they need it the most, right? So if you actually spend time talking to people, talking to women and their experiences, they will share with you the solutions, right? They're very clear on what the solutions are. They're very clear on saying that perhaps the providers need a certain amount of training, not just in cultural competence, which is really important, but a sense of cultural humility, right? There's a difference in that understanding and that language. And when you communicate, is it in a way that I'm going to understand? Is it in my language, right? So my team who's here, shout out to them, thank you so much for being here. We spend a significant amount of time on saying, how are people going to receive this information, right? Are we doing this in a way that's very collaborative? Because if our job is to really move the needle, that is the way that we are going to do this. I can't talk at you, right? It's a conversation with you. I need to center your experience. So very conscious about who has the opportunity to present when we're talking about solving problems, right? And I think it's also really important for us to know. So I am a product, my mother was raised in the Jim Crow South, right? So understanding redlining is not anything new, right? And we need to understand that legacy, that history, because trauma and oppression is generational, right? It is passed on. So when our providers are asking about your family history, because they want to know, did your parents, your mother had breast cancer, did they have heart disease? They might want to know, did your mother grow up in the Jim Crow South, right? What was that experience like? Because when I walk into an exam room, I am the embodiment of that experience. It's not separate, right? It's not separate at all. So we need to understand that. And thinking specifically about policy is so important, right? So we can think about voter suppression, we can think about gerrymandering, and how that impacts our bodies. One of the most important things that we should be thinking about now in this post-Roe v. Wade era, in order to address this, is the ability of Black women, Black birthing people to make decisions about their bodies. And that is a political issue, right? That requires collaboration with policy and lawmakers. So I'll stop there. Thank you so much.
But my God, we wish you would keep going. Surely we wish we had more time, but you teed up so perfectly, Dr. Williams, exactly where we are going next, and that is policy, policy, policy. So everyone enjoy 5 minutes to do what you need to do. Grab a cup of coffee, grab some water. Our panelists, please join me over here at the Step and Repeat for photos. Ladies and gentlemen, we'll convene in 5 minutes for panel 2 on policy. Thank you. That was phenomenal. Okay, welcome back. Everybody hydrated and refreshed? Okay, all right. Well, wow, I am surrounded by some real power players here, and it is my honor to now engage in part 2 of this robust conversation, which centers the policy piece and the legislative solutions as we eradicate Black maternal mortality. Amen? Amen. Okay, thank you. All right, I will start by introducing you to Senator Samara G. Brooke. Okay. Senator Leah Webb. Assembly Member Rodneyce Bichotte Hermelin, yes. Assembly Member Miguel, yes. G.C. Solange. And Council Member Farah N. Lewis. And, of course, Latifah Ford. All right, ladies, thank you so much for being with me here. There's so much to get started on. So we're going to start with something that I think is very important to foundationally level set all of our stakes here, right? And I think I will start with Senator Brooke right here. Talk a bit about, yes, ladies, everybody got a mic. Tell us, Senator, your why. Your why. This work is so comprehensive and it's important to all of us, but we all have a story of some sort, I think, that personally tethers us to this mission. If you could please share your personal buy-in.
Going right in. Okay. Good morning.
Good morning.
And thank you so much for being here. I just want to say you can tell how important this topic is to all the legislators up here because we are 12 days away from Election Day right now, and we're taking a couple hours to talk about this because the work doesn't stop. And so the quickest answer as to why I do this work and why I'm here and why this is so important is because Black lives matter, Black mothers matter, Black babies matter. And I believed that before I ever thought I would be a mother, and I believe it even more now that I am a mother. So 2 years ago, I had my baby girl.
Yay.
Another L name, but not Liberty. And actually found out that I had become the second sitting senator in history to give birth. The first was Velma Montgomery, senator from right here in New York City, who had done it over 30 years prior. And I insisted on having a doula for that process, and I can tell you without a shadow of a doubt, I would not be sitting here healthy with a rambunctious, beautiful, brilliant 2.5-year-old at home had it not been for the doula that I had. And it was both in small reasons and major reasons, right? And so the small were, you're in Albany alone at the Hampton Inn, you know, and you're pregnant and your husband is over 3.5 hours away at home in Rochester, which is where I'm from. And you're panicking, and I thought something was wrong with the baby, and I thought I was feeling pain, and it's a high bar to call your nurse's line, right? And that your nurse is in Rochester, and you know they really only want you calling for true emergencies. And I said, well, I don't feel like I should call her, but I'm going to text my doula at 11 o'clock at night and explain to her what was going on. And she was like, you know, let's tell me about your day. Oh, you read a really scary story on Facebook, right? About someone whose actual, you know, their baby was in the NICU. And she's like, okay, maybe that's related, right? Drink some water. Why don't you take a shower? And she brought me down, right? From that panicked mode. And those seem like little things, but that could have gone into high blood pressure. That could have gone into, no, I do want to go to the emergency room. And then we know what happens to Black women in our medical system. And then in the bigger ways, for me, I was moments away from an emergency C-section. I was in the hospital for the total of 4 days. And I looked at my doula, Phyllis, and my husband, Brian, and I said, I need a minute. So doctors leave, nurses leave. I need a minute. I have to deal with the fact that I'm not going to have the birth I thought I'd been planning for months. And my doula talked to me again. She was my support. All of a sudden, my blood pressure goes down. Your body gets ready, and 20 minutes later, I had a baby after 2 days. And so I thought to myself, why is it fair that I get all this support and not every New Yorker does? And so that why. That is my why when it comes to fighting maternal mortality, and specifically to make sure every New Yorker gets a doula that wants one.
Amen. Yeah, and I feel the exact same way, Senator. You know, it's one of those things where it's okay to name our points of privilege in this society and know that if even the most privileged amongst us as Black women still have stressors and challenges, my God, what is the everyday New York Black birthing woman person experiencing? So I thank you for being vulnerable and sharing that. Senator Webb, care to share any personal attachment? Doesn't have to be your own story, but just your why.
Thank you. I would say for me, I actually got my start well before being in the Senate as a community organizer working on healthcare, and I recall countless stories of women experiencing challenges in getting access to healthcare, but the big determining factor, even when you had the same insurance, but because you were Black, you had a different experience, whether it was going to the emergency room, whether it was getting to see a practitioner, all of those things. And so seeing that, but also experiencing the impacts of systemic racism with my own mother and navigating the healthcare system and understanding that if you didn't have an advocate standing up for you, that it's very easy for marginalized communities to be left behind. And we have the data and the statistics to demonstrate why it's important to address the systemic and institutional barriers that create challenges for everyone to thrive, whether you are aspiring to be a mother or you just want to be an auntie.
Yes.
I'm a proud auntie.
And we need them.
Okay, there are other aunties in the room. All right, and also I have a lot of sisters, like literally, and like family-wise, and through association, all the things, and again, thinking about their experiences, witnessing the birthing process for them at the various stages of their journey, all of those things, similar to my esteemed colleague and friend, Senator Brooke, with regards to knowing that everyone can and deserves better. And so from a policy standpoint, as a public servant, we know that policy can heal or it can harm. And so having people in all the various positions to provide that wraparound when the system and the institutions fail. How do we change that trajectory? All of those things are most certainly my why for doing this work.
And it's so important, Senator Webb, because you don't have to be the individual that aspires to or gives birth. Let's be very clear. If we are to be solutions oriented here, it will be every person occupying space in the community, having the knowledge, having the understanding, and making a collective shift around the culture of what it is to give birth as Black women and birthing people in this state and in this city. So thank you for that, Senator. Thank you. Assembly Member Bashir Harmelin, share, please, your why, if you don't mind.
First of all, thank you for inviting me. Thank you to Rosemont Pierre-Louis and NYU McSilva for having this, because this is very important, especially this month, which is Pregnancy Loss Awareness Month, okay? I want to say that my why is because I was a victim. I'm a survivor, a Black maternal survivor. This year marks the 8th year of losing my son to bad treatment. October 7th in 2016, I was experiencing preterm labor in a very well-known hospital, did not want to serve me. I was 3 centimeters dilating, and they just didn't want to touch me. They were like, hey, we can't do anything, go home, have the baby, call 911 when it happens. So pretty much that hospital left me to die, and pretty much left my infant to die. Fortunately, and which is why it's very important to have diverse representation in legislation, I was picked up by a community hospital called Wyckoff in Brooklyn, and they did everything that they could to save my baby and myself. Unfortunately, my baby was born very preemie, and he didn't survive past 2 hours. And it was a very tragic experience because I was not expecting that. I had my sisters, Mikhail Solage and Councilmember Farrah Lewis, who was there with me in my living room, consoling me, feeling my pain.
Yes.
I took the step of not to sue because, going through litigation could be even worse for you.
Yes,
okay?
great trauma.
And I decided that that's not the route that I want to go. I wanted to actually pass the legacy in my son's name by introducing a bill called Jonah Bishart Cohen Law, which mandates hospitals to take care of anyone who is dealing with preterm risk and should not push them away. If the expecting mother decides not to stay in the hospital, that is at their will. And so ever since, it's been my mission to push legislation and promote awareness in preventative care to make sure that Black women, women of color are not dying in the hospitals and their infants are not dying in the hospitals. So collectively, you see a panel of women who's been working on the city and state level to push laws, because laws can be real and there's penalties for laws when you don't abide by the laws. And this is something that we haven't had for years, and now we have these great women who are standing up, pushing up bills. We pushed a lot of policies such as, and you will hear from Mikhail Solage, but breast milk, maternal depression issues, a lot of stillbirth. Very often we lose our children or our child and there's no resources for those who lost their child. I mean, it's just okay, you go about your way. But then there's postpartum depression that goes with it, suicidal, things like that. We have pushed bills like there's a situation where a Black woman, she lost her baby died in her, and she had to wait 2 weeks to get the baby removed because we don't have enough OBGYNs or specialists to remove in some hospitals, which is the hospital that she was in, which was a religious hospital, considered that abortion. And so there's all these different things that we have to take accountable for, into account. So that has been my mission, doing not only legislation, but forums. We had a number of forums in the past, and we continue to do so, and we want to be very inclusive.
Thank you so much for sharing that deeply personal and so powerful and transformative piece of your story with us. And we're also sorry for your loss, but we're so proud of the work that you're doing.
I do want to say that I was blessed to have had another chance in life and another chance in giving birth. And I do have a 2-year-old son by the name of Daniel.
Yes, amen.
Amen.
Beautiful. And Assemblywoman Solange, can you please share your personal buy-in?
I'm gonna take a page of our great Vice President Kamala Harris and say that I don't aspire to be humble when it comes to policy.
Yeah.
I want to use it as a blunt tool to empower communities and ensure, especially communities of color, we gain access to economic, social, and also healthcare, policy and benefits that other communities are lent to. So, I have 3 wonderful children, and 2 of my pregnancies, I had extreme complications with them. As the senator said, I always wanted to have that natural birth, the vaginal birth. You have that vision in your head when you go into the maternity ward, and unfortunately, I've never had the chance to do so. And I remember sitting there when the doctor first came in for my first pregnancy, telling me that we have to do an emergency C-section because my water broke early, and I spent 2 days trying to go into contractions. They gave me the Pitocin. They did everything possible to try to get myself dilated, and I couldn't do it. So they did a emergency C-section, and I remember after saying, "Oh, I didn't give birth." All that negative talk that society has put into us. And then for my second birth, I was going to do a VBAC And I was so excited because, you know, I was approved for the VBAC. You know, I was waiting in, you know, a hallway to get into, you know, a room. They transferred me to the bed. I was about 8 meters dilated, or whatever the term. I was extremely dilated. They were putting out everything for vaginal birth. And then all of a sudden I started feeling pain because they gave me the epidural, but I started feeling a lot of pain. And I was like, why am I feeling this pain? And they got scared and they said to me, oh, well, we're gonna have to do a C-section again. And I remember saying, look, I wanted the vaginal birth, you know, this is what I want, you know? And unfortunately, they said, no, you know, the liability is gonna be on you if you don't allow us to do an emergency C-section. So they put me into the emergency room.
I'm sorry.
What?
I'm so sorry.
Yeah.
I'm so sorry.
Oh, no, no.
Right, yeah.
The
litigator.
Yeah.
The litigator.
Oh, no, listen, no, it gets worse.
Yeah.
So they put me into the emergency section. They go and they put the knife in me and I feel it. And yeah, and then I pass out because then the anesthesia got in. Lo and behold, the epidural fell out, but no one checked. No one checked. Isn't that crazy? No one, but the thing is, when it comes to our pain, they don't believe us. They didn't check, they didn't see. I wanted to sue, trust you me.
Yeah.
As a major hospital, I wanted to get my payday, but but I decided not to because, again, reliving that trauma. But I share this because I know many of my colleagues don't know this. I share this because at the end of the day, they don't believe us.
Yeah.
And we're gonna force them to believe us because we're gonna change all the laws, all the rules, get more healthcare workers that look like us, make sure they have implicit bias training, everything. I'm gonna throw all this table, anything. Because I do believe that we need to change the dynamic. Because my story and the stories of other women who have passed should not just be something that we glaze over. And so my why is that this is work we have to do.
Amen.
And we cannot wait.
Unbelievable. Unbelievable. Council member, your personal why, whatever you want to share.
First, I want to thank Mick Silver and Rose for the opportunity, and thank you for moderating. We appreciate you.
Thank you.
Let's give it up for Ebony. So when I was born on the floor at Downstate Medical Center in Brooklyn. And then my little sister, who's 6 years younger than me, also was born on the floor at Downstate Medical Center. And it started that long ago for me. But I think the pinnacle moment for me, becoming a legislator now, I was working at the time for a legislator, got a phone call from a woman who had just lost her baby at a hospital in Brooklyn. She said, they killed my baby. I just had birth a couple of hours ago and they killed my baby. So I contacted the legislator that I worked for at the time and I said, listen, this woman called. She said that they killed her baby. She just gave birth. And the hospital didn't want to basically be accountable to what happened. So in doing work and investigation, within hours, we found out that the nurse was negligent. They sent this woman home. We couldn't find her. And it was just so unfortunate, and I think about it now being a legislator. At the time I was a staffer working for someone. We sent this woman home to just bury her baby. Fast forward, from that time, that was 2015, my friend, legislator, Assemblymember Rodney Bashot, we had to enter a room not knowing if we would see her the next day. Because we didn't know if it was gonna be her or the baby that we would lose. So there's so many different stories, but then when I became a council member, I knew that we had to do something proactive. I appreciate Speaker Adrian Adams because in 2022, we passed a historic package of maternal health bills, 11 bills, to address the maternal health issue we have here in our city. And within that package, we passed the first ever, we established like a pilot program for doulas, to train doulas and to expand doula services around the city. Mayor Adams then gave money towards it. And that was, for me, a successful moment for our city to know that we actually wanted to make investments, but to change something. Now, we are preempted by state law, but what I'm grateful for is for the women that are up here, whenever they see that we're trying to pass a resolution, they pick it up and they run with it. They take it to the finish line. So I'm so grateful that my mom went through that experience, knowing that she had to give birth on the floor at Downstate Medical Center. By the way, Downstate is no longer like that. We got some really, really good doctors. At the time, the institution was mainly white males. And at the time, my mom's provider at the time was a Jewish man, and it was Rosh Hashanah, and my mom was ready to give birth, and he was observing, and they couldn't find him. He still left his house on Rosh Hashanah and came because no one would attend to my mom. Wow. He still came and made sure he got to the hospital in time so that he could continue to support my mom through her birthing process. Now, he's not supposed to do that, but eventually it would have either been my mom or myself. The same thing happened to my little sister at the same institution. But I think Dr. McCalla said it while he was up here. It's institutional and systemic at the same time. Somebody has to decide to make the change. Yeah. Whether it be the doctor, the institution as a whole, or the legislators, everybody has to come together. So I'm grateful to be in this space in order to support changing maternal health here in the city.
Fabulous. Thank you, Councilmember. And we're gonna give every legislator on the stage an opportunity to tell us about legislative victories and things that are in the pipeline. But before we do that, you use some language. I just want to make sure that we're not taking anything for granted here. You talked about state law superseding that of city. So I'm going to call on our state legislatures here. I'll start with you, Senator Brooke. Talk about how the municipal piece works with the state piece collaboratively so that things aren't getting in one another's way.
Well, it was kind of our city council person to say that we do try to be collaborative. I think that at least from my perspective, and I'm a few years in, so I'm in my second term as a state senator, so I say I still think like a normal person and not like an Albany person, but try me back in 10 years, so we'll see how it goes. But one thing that I notice when you're looking at municipalities, in particular places like New York City, right? Oftentimes what I think as state legislators we can do is learn from what works for localities. Now, with New York City, it's interesting because if it works in New York City, it can pretty much work anywhere, right? Largest city, very diverse, complex metropolitan area. But there's also lots of local cities. You know, my city in Rochester is probably the same population as like a couple neighborhoods in Brooklyn. It's a 211,000 people, and not even 1 million in our county. So there are opportunities that our localities have to pilot things, and they have a little bit more freedom within that piloting, other than making it a large program, because state law might, stop them from doing that. So one thing that we've been able to do is, in some cases, even help fund pilot programs, like if we look at the doula programs, right? So New York City was ahead of the game when it came to training doulas, increasing reimbursement for doulas, and because they were able to do some of that, it actually helped put wind in the sails for what we tried to do on a state level, where we were also trying to, one, get Medicaid reimbursement for doulas, which I know if you're in this room, you already know that represents about half of the births in New York State are under Medicaid. So you're talking almost 100,000 births. And interestingly, 65% of Black births are covered with Medicaid. So in New York State, we wanted to get Medicaid reimbursement for doula care, and we wanted it to be higher than it had ever been. And places like New York City, doing that on a city level, help push the envelope in some ways to allow us to do that. So I think there's an example of where we work together, and there's other examples where the cities want to do more and they have to come up, and as y'all did, come to Albany and let us have it. And for most of us sitting up, I'd say all of us sitting up here, we're usually ready for that conversation, but we also need that backup, right? Because we have to also convince our own colleagues. And I just want to say, I think a perfect example is the majority leader, who is honestly the most phenomenal leader, and she's not even in the room, I'm just saying this, most phenomenal leader you could ask for. I don't know what this job looks like without her, because she's just, so amazing and thoughtful and deliberate. And as she described, we literally had to educate people on what a doula was. Yeah. I mean, we joked that I changed my middle name to doula because I was talking to, my 75-year-old male colleagues whose granddaughters were like my age. And I said, do you know what a doula is? Let me tell you what a doula is. This is why it's so important. But having partners from city government who can also come up and do that really allows us to be unstoppable.
Amazing, amazing. Senator Webb, do you want to share around that?
I would just say really quickly that as a former local official myself, I most certainly understand what happens when the state kind of creates a parachute and leaves out the localities. And so to Senator Brooks' point, we actually do have great rapport, but with our local officials, most certainly through our respective caucuses that we have in the state legislature, where to Senator Brooks' point, they lift up what are some of the things that they're working on, whether it's policy, but also providing us with data. So when we are pushing for legislation and funding, because it's not all just simply legislative, it's also the budgetary investment that also makes a difference. And it helps us to create more supports across the state because there's work that's already being done. I'm gonna lift up really quickly, Senator Brooke didn't mention this, but last year, we did a public hearing because not all the ways that we advance change is simply through policy and through budget. We also create space. And one of the ways that we create space is creating or doing public hearings. And so Senator Brooke led a public hearing. I was a part of it along with some of our colleagues to do a public hearing with respect to doula care here in New York State. And one of the things that I most certainly took away from that, which led to us increasing reimbursement rates along with expanding more policies, this year we actually introduced a 12-bill package around maternal and reproductive health care that was lifting up things that came out of that public hearing, but also the work that had been done and was being done at the local level. So things like establishing a maternal health and birthing work group that's statewide, that takes into account what's happening with our various stakeholders in our healthcare system with respect to addressing maternal health outcomes. Now, only a few of those bills passed both houses, and we have several that we are still waiting for the governor to sign, but that's another conversation because we're still in the bill signing process. But I lift those examples up to share that this requires us to stay in constant communication and community. Because when you're talking about addressing complexities associated with maternal mortality and other aspects of maternal care, you can't do it in a silo. And that's part of the problem. It's like this person over here is doing great work, this person over here, but there's no connector point or it's so inconsistent. We're often, playing catch up. And the reality is the work that we do is having real impact on real people in real time. So that is why it is imperative that we collaborate, especially on issues that we're discussing today.
Beautiful. And my deep apologies. How in the world? Thank you. Yes, yes, yes. Ms. Nafifa Ford, I am so sorry. I failed to create the space for you to share your why as to why you are personally tethered to this work. So please.
Well, thank you for that. But I was so ready to give my
too.
policy response on this. But thank you for creating this space. And I just want to thank Rose, the McSilver Institute, and NYU for just really kind of convening and bringing folks together to really address this. And thank you, moderator. I think my why is a few different things. One, it was my experience with my younger sister who went through her birthing process and actually had a son who transitioned after because of the lack of care in a hospital in Brooklyn. And just being responsible in how you care and how you deal with the voices that are telling physicians what you think it should be, but you're not a physician. Like maybe that's too much medicine for a newborn and a preemie, right? So little things of that nature. So how is our voices in this space? And then the other piece that I think is my biggest piece is just my own personal journey. I am a new mom, so it was. And I'm actually here, my doula's here, my baby's here, so she comes where I go. she comes where I go. So we're not even 2 months in, so I'm getting the hang of this. So I'm just gonna embrace that. But I did have, and you mentioned it's important to mention your privilege. My privilege was my knowledge, my information, and hearing all of the stories and being tapped into a lot of the different work. But also because I'm in the place as a policymaker, someone who kind of creates the policies and really the programming, I knew. So sometimes your knowledge is really just your privilege. And the knowledge that I did have just really I was so intentional about having a doula, wanting to have a midwife present, wanting to know who the OB was just in case, but really kind of outlaying my birthing plan with so much intentionality. And I think even when my midwives came into my room, I was fortunate enough for them to say, this was probably the most tranquil room I came into. I was just like, it was very dim lit. There was sounds playing of the earth. And I asked everybody, I was like literally quiet on set. That's literally what I said. And every time I would come in, my midwife would just remind everyone, I don't think she wants you talking. Because I knew how I dealt with pain. And I was so afraid of the pain and so afraid of the stories that I heard, that sometimes it's important that you do tune a lot of things out as you're going through things, because those stories that you hear about people birthing, their birthing stories that were unfortunate and really avoidable in a lot of spaces scare you. So I didn't want it to scare me. So I just was like, quiet on set, this is what it is. And I have a mother who's not very quiet. And I was looking at her a lot like, girl, give me 5. I'm extending grace, allowing you to be here, but quiet on set. But I will say, all of the work that was done, all of the legislation that was passed, all of the information that I came in with really did create an opportunity for me to have what I consider a really relatively easy birth. And I do have to thank my doula, my midwives, and really the institutions that I went to that was so tapped into what I needed. I will say, before I went there, I literally went through 3 different OBs. So when I say intentional, I mean walking, this is an OB I've been to for many, many years. I said, you were good for this, but you're not going to be good for this.
That's it.
And I left. Then I went someplace else and I was just like, I love you, but I can't do your staff, right? Like, it was just like, it was too much. I'm waiting too long. I just felt like this was not going to work. So sometimes that trusting your voice and trusting that thing inside of you is not something that people teach us to do. It's not something that our institutions really kind of tell us to do, but that's something you got to own on your own. And if I would say, as a woman of color in the space, and Black women and specifically, you know what you're experiencing to be true. You understand your body, and the reality is, be okay with walking away and finding the institution that is really going to support you. And that's a lot. It's risky. It's risky, and I actually came out, and it worked out for me. But I will say, I had to walk away. And it was okay. They aren't bad people. They weren't bad institutions. I just knew for what I wanted, this would not be conducive to the birthing stories that I wanted for my baby. Yes. So for me, it was literally that intentionality and really kind of tapping into the piece of being knowledgeable. But I will say the last piece is, prior to working for, I'm the executive director of NYC Her Future, which is a new office that's really dedicated to address the disparities for our young women across the city. But prior to that, I was the acting executive director of the New York City Young Men's Initiative. And I would always tell people, and I was there for some time. So prior to when all of this, I always go, the CDC called this stuff out years ago. Yeah. So if we really think about it, we're behind the curve on a lot of things. And when I worked in Baltimore, Be More for Healthy Babies was doing a lot of work around this. So when we have to think about where we are, we have to think about where we are and where we're coming from. The data has always been out there. But at the time, when I worked at YMI, I would always go, we can't talk about the lives of our Black and Latino boys until we talk about the wombs that are birthing them. If you don't have a chance from the womb, if you don't have a chance from the womb, then it's nowhere you can tell me that somebody's going to care about how you persist through life. So a lot of this is systemic, but a lot of this, and I'm getting chills when I say my own stuff, so that's a problem. But it keeps me, you ask for my why, that's my why, because we can't talk about how we advance as a society, but how we thrive in the Black community until we think of this as a community. So I really appreciate the word community that was lifted up on the last panel and this panel, because this integrated health is a community, it's a community issue. We cannot talk about the lives of Black boys, we cannot talk about the lives of Black girls until we talk about the wombs that are holding them, and that is sacred.
Amen. Powerful. Yes, yes, yes. Powerful, and congratulations, she's a beauty. Woo, okay. Just going back to the legislative piece, because I do want folks to leave here this morning with maybe not all, but some specifics. I'm looking at you, Councilmember, because you talked about, I think, an 11 piece. Can you kind of walk us through some of that?
There's a lot.
I know there's a lot. That's why I say some of it. And also, there should be a QR code if we could have tech put up so that, or the website or something, so that people can access the comprehensive offering of what the legislation is looking like. Yeah, there's the QR code. Please, please, please take a picture or screenshot that to yourself right now so that you can see it in its full capacity.
And share it with a friend.
And share it with a friend.
So Introduction 472 to establish a citywide program to train doulas and expand doula services in all boroughs is a bill that I co-primed on with Councilmember Gutierrez. We started off with $750,000. I think we're now at $1.5 million to fund doulas around the city.
Are y'all able to hear the council member?
Can you guys hear me?
Okay.
Oh, okay. There we go. Microphone check. All right. Some other bills that we passed in that 11 bill package to increase access to critical data and maternal mortality and morbidity, supporting targeted improvements to maternal health care. That was Intro 409. I'll do one more. Intro 86, promoting respectful care during childbirth by improving access to patient rights and health care proxy information. One more I'll do. And Intro 478, it was a really good package. Advance a public outreach campaign on the benefits of doula and midwife care. Because I think someone mentioned earlier on the panel that not everybody has the information.
Yes.
So public outreach campaigns are really important so that folks know what they have access to.
Sure.
What I'm really proud about, we passed that in 2022. In 2024, we just passed another maternal health package, but the focus right now is on maternal mental health,
Right,
which I truly appreciate the speaker and all of the sponsors. I'm one of them for this new package, which will now establish a pilot program to help with postpartum care.
Excellent.
And some other maternal mental health supports that are needed in the council. So we're moving.
Yeah, and I just have to highlight, Dr. Robinson, giving us some foundational, understanding and context of just how correlated that work is around the mental health piece. So thank you for that, Councilmember. Assembly member, oops, sorry, don't worry about that. Assembly member Solange, I want to ask you, I'm going off script here. So a lot of people saw a recent New York Times article that highlighted a study that took place in New Jersey that talked about unnecessarians and the fact that Black women specifically are being essentially forced into cesareans in ways that are medically unnecessary. And I think we all kind of just understand how problematic and ultimately deadly that can be. Can you speak to it and let us know if there's specific conversation around that policy piece?
And also remember that you can only have a certain amount of cesarean sections. So then it limits our ability for us to have children and grow our family.
I did not even know that until this moment.
Technically, you're only supposed to have 3 C-sections. You could have more if you have a good professional, but 3 is the limit. So really, it's debilitating our ability to have a large family if we choose so. But this is the problem that the New York State Legislature actually is trying to tackle because it's first of all, the hospitals are looking to do it because it's an easier procedure, less liability when it comes to it.
They get more money.
Unfortunately. And yeah, and there's great hospitals. I'm not talking smack about the
Sure.
hospitals.
No, no, no,
no.
no, this, we're not
you know,
demonizing,
yeah, we're not demonizing anyone. Yeah.
cesareans, right? Because they
for
can
them,
save lives, but also
for them, it's an easier process,
Yeah.
less liability, and they also get higher reimbursement from
Yes,
it. And so for them, it's about the dollars and cents. So in the legislature, there is a bill carried by Amy Paulin to limit or talk about how hospitals can limit the amount of C-sections happening here in New York State. And it's a piece of legislation that we're trying to push forward. We unfortunately were not successful this year, but we want to make sure that this is an option where it's medically necessary and not a convenience for the medical professionals. And so this all is intertwined with the conversation of having a doulas, more midwives at the table, and also ensuring that we have birthing centers. Because birthing shouldn't be a business. You should be able to go to a dedicated location that specializes in birth and be able to be assessed there and have a vaginal birth that you desire. So we're looking at it as a state. It's a difficult dynamic because medical professionals say that, oh, we need this tool in our toolkit, but I think they're abusing this tool in their toolkit. And it's something that, especially as Black women, we are more likely to get C-sections because for them it's just easier. You have pain, you have issues. Let's just take out the baby, and that'll be better. But instead of making an assessment, and I see you at the end looking, instead of making an assessment, they choose to do this. So it's something that we're looking at, and we need advocacy on the bill. So if you're interested, it's an Amy Paulin bill. I don't have the bill number on top of my head. What?
It's a Brooke bill.
It's a it's your bill. Oh,
it's your bill.
Oh,
Come on,
so
give me
you
flowers.
Go. So go ahead. Yeah.
No, you said it great. Yeah, I can give you the bill number afterwards. No, that's great. No notes.
No, give them the
Give
bill
the bill number.
now.
Yeah, I'm done.
Oh, okay. I was like, no, this is very, very important. Go ahead.
I was about to say, and this is how we kind of work together because folks are like, oh, I can co-sponsor that, right? So this is how you push legislation forward. And then on our end, it's like, well, what programs do we need and how can we tap into the Office of Budget Management to kind of create new programs to support a lot of the bills that are coming out. So this is, these spaces create a lot of the work on the ground. So this is also how you build in community and with community. So I appreciate that.
Yeah, and I'm about to put it on hold in court because it's definitely, no, I'm dead serious because I was within moments of what I know to be what would have been a medically unnecessary cesarean. And it's happening every day to women that look just like us. And it's a problem. And what they don't often cite, they cite the purported decrease of liability, but they don't talk about the increase of risk of sepsis and infection and hemorrhage and all of that. So there's a
it's an abdominal surgery. It's
a
serious,
major surgery.
Anyone who's had a C-section, it's a very serious procedure. And even after, they don't even give you the tools that you need to recover, and they don't even advise you. I remember when I had my first C-section, they were like, "All right, good luck, bye." And I was like, "What's going on here?" And it's a huge problem that we need to address, and that's why this legislation is so important. That Senator, we got to get it done, right?
Yeah, we're gonna get it done. Yeah, get it done. Okay. Any other legislators want to share any specific? Yes, please.
I just wanted to point out. Well, first of all, with Black women, we also come into this journey with a lot of complications, right? We have fibroids, and so very often, like me, I had issues with my reproductive for a very long time because I had fibroids. And so as a result, I had to have a myomectomy. Once I had the myomectomy, I was told I could not have a vaginal birth going forward. That's what they told me. So it was expected. And a lot of Black women have myomectomies and fibroids. So I know that's an excuse sometimes, like, okay, C-section automatically. But what I would like to say is that what we do as legislators is also we take every single step of our journey and we turn it into legislation. You talked about the impact of C-sections and hemorrhage. Like very often, people or the doctors or the healthcare workers may not know that we're bleeding inside, or we're hemorrhaging. And when we're saying, "Hey, we're hemorrhaging, we're bleeding, what's wrong?" they don't do anything. And so we've had legislation that turned those kind of specific tragic moments into real laws so that people can be aware. I mean, it's a whole spectrum of things that we have to look at. You know, you talked about implicit biasness, it's competency, you know, cultural competency. It's also language barrier. I would say in the Africana diaspora, Haitian mothers were rated the highest rate in terms of maternal mortality. And the reason why is because there's a language barrier. You know, you're black and then you have an accent and then you can't speak English. And we have a lot of Haitian doctors, but for some reason, they are not placed in areas where a lot of our Haitian mothers are at risk. So I just wanted to read a little bit more bills that passed, and we also wanted to share with you with what the governor also have a 6-point program regarding. So some of the bills that we passed the first nation-paid prenatal leave, providing 20 hours of paid sick time for pregnant employees. So that's good. We codified the Reproductive Freedom and Equity Grant Program to provide funding for abortion providers and nonprofit entities. We had a bill called Mickey's Law again. Hospitals were not allowing women who had dead fetus to abort their fetus, right? They said this is abortion. That was a problem, and people were waiting for 2 weeks. So we did pass a bill that did that. Enacting the community doula expansion, you heard about that. It's a grant program to provide community-based organization for recruitment and retention. We also had allowed the health commissioner to issue a statewide non-patient specific order to provide doula services for any pregnant, birthing, or postpartum individual. And we also had bill requiring paid breaks for breast milk expression in the workplace for 30 minutes. That's Assembly Solage's bill. Yeah. And now the 6-point program established, this is by the governor, established the first in the nation, and I mentioned that the prenatal leave, paid leave, which is a study that showed prenatal doctors' appointments are tied to better health outcomes for moms and babies. We talked about the expanding of the doula services, out-of-pocket medical costs for pregnancy-related benefits for New Yorkers relying on the Essential Plan and other qualified health plans, unnecessary C-section that put mothers at risk, and then also the postpartum depression by deploying new training and resources for maternal health through 988 Hotline expansion. So we talked about the maternal depression. That was I think they found that was the third contributing factor to maternal mortality. Wow. And so that's something that's really big, especially in the Black community, because very often when we go through pain or mourning, we don't mourn, we don't have any resources, we just have to go on with our life. We go back to work. I know when I had lost my child in 2016, I said I'm gonna take a month off, and people were not expecting me to do that. They said, no, you need to go back to work. What do you mean you're gonna take a month leave? It was very disrespectful, and I had to go through that. So, you know, we have a lot of these put in place to address these issues. I do wanna say one more thing is that we're talking about maternal depression, oh, that's a high contributing factor. But still, we're not discussing about the primary contributing factor, which is racism.
Yeah.
And this is something that we took back to the governor's maternal task force. There was a whole report on maternal depression, but I didn't see the report on racism, which is the first reason why a lot of our Black mothers, women of color, are dying. So something that we should, again, take into account in how we're going to resolve racism in the hospitals, racism in this workplace.
And I think it's worth noting to the racism piece, and I kind of like to specify the anti-Blackness of it all, right? Because that's a very acute way in which this thing shows up and kills us, right? You don't have to be white to hold anti-Black views. I'm gonna say it one more time. You don't have to be white to hold anti-Black views. So it's very important that, and the data bears this out, right? That's not just me opining. No, really though, right? That even when we have the privilege of having a Black medical care team, from Black OBs, Black nurses, Black doulas, Black midwives, God bless them, there still can be moments where that anti-Blackness shows up and it kills us. So go ahead, yep.
So I do want to just, for me, ashe to all of that,
Yeah.
because I think it's important that we pull up the racism piece. And on top of that, I think it's something that we don't talk about when we think about always the problems. The solution starts with womb health. And how do we talk about our wombs? And how do we talk about our wombs at an earlier age to our young women?
Yeah.
The moment you experience your menstrual cycle, that is the beginning.
Yeah.
Right? You're born with all of your eggs. You're born with all of those things. So how we impart wisdom on our younger generation is really, really critical. And for me, sometimes that's the work that we tend to really lean into at NYC Her Future.
Right.
And the other piece that I do want to lift up is this piece of weathering, right? When you talk about the internal being of Black women, you could present as this beautiful 25-year-old woman, but the trauma you've endured throughout your life, when they look at your insides, you look like a 45-year-old lady, right? And think about it
Hey, easy
as
on
you
45,
get.
easy on
No. Think about it. Think about it. So even in your 45-year-old body, you're now looking like you're 60, right? So we have to be intentional about these conversations and the type of stress that we're enduring on our women, children, because that weathering that happens inside of our body, on top of the thyroids, on top of them really kind of, we're not even addressing the number of young Black women that are being told to get hysterectomies. Like, it's a lot of stuff that's happening now. And I think, and I took notes at the last panel. So the last panel kind of spoke about, like, Roe versus Wade, this thing about decisions about your bodies, the decisions of Black bodies are in the hands of policymakers. So when I say literally, we got to applaud ourselves and applaud these women up here, because it has to be them. It has to be us up there to really kind of ignite change and make sure that our stories are a part of the policy, because as you said, right, policy can be healing. So I want us to really think about it and really think about the weathering, because in the workplace, I always tell the women, I go, don't have them in here stressing out your womb. And they laugh, but I go, don't have them in here stressing out your womb. So if you need that mental health day, if you need a vacation, you are entitled to that. Take it off and take those moments to really center yourself and do the work before you're becoming a mom. Because a lot of the work we get, and that's even on my end, it started when I became a mom, right? Like, go to therapy, have these conversations. But that journey could have started a long time ago. So really kind of be in tune about the weathering that's happening inside of our bodies.
Thank you, Senator.
I wanted to add, as we're talking about maternal mental health, and there's all these studies on the weathering too, of how the delta between non-Black and Black birthing people actually gets bigger the longer we're on this earth, just being Black women. I'm one of the statisticians can get that study, but I remember reading it. But I wanted to just go back to some of the mental health piece, because for me, again, the leader talked about starting the mental health committee in the Senate, and so a lot of my work is as chair of the mental health committee, but I can't ignore also being a Black woman and a mother, right, going through that process. And one of the most startling things to me was learning that maternal mental health conditions were the #1 most common pregnancy complication, with 1 in 5 people facing it. And on top of that was that it was so much more than postpartum depression. I really mostly knew about postpartum depression. I didn't know that it could also be OCD, anxiety, all of these maternal mental health conditions that it seemed most people, at least in my world, weren't aware of. And so then when we're thinking of legislating it, are we really facing the entire, complexity of maternal mental health? And so one of the things that we did legislatively was try to match what we've done at a state level with maternal mortality and morbidity, right? We have the review board, and actually study maternal mental health conditions at a state level. And so I know sometimes people want to hear about that policy process, right, and how you get it through. Well, with the support of everyone up here, every state legislator up here, we passed the bill in both houses, and I think it was in 2022 that it was vetoed at the end of the year, and so we weren't able to get it passed. But then the governor said, reintroduce, let's work together. So 2023 came, and due to this advocacy, we were able to get that work group actually into the budget with $250,000 behind it, to have a voluntary work group set up so that we could specifically study maternal mental health. And here's what I believe the biggest win of all of that is that when you're a part of a voluntary work group body, and I'm sure many of us here are on commissions, right? You don't get paid. I don't think a lot of people realize when we say voluntary, you are offering your services, your expertise, you're traveling to Albany or New York City or joining the Zooms. I think you can get a little bit of gas money and maybe if you need to stay at a hotel or something, but you don't get childcare reimbursement. So if we're starting a maternal mental health work group, asking mothers who've been affected by maternal mental health conditions and not giving them a childcare reimbursement, how are we actually making this inclusive? So this is the first statewide work group / task force that will reimburse for childcare. And when you think, yes. And so, you know, like you said, not to toot our own horn as legislators, but it does need to be us in these positions so often because I'm thinking of that. How many of us have to bring our children to Albany once in a while / a lot, right? And Daniel and my little one are close friends, although he has more hair than she does. But you know, we think of these things. And so I think that, again, we think of like these little tweaks that we do and then these massive like statewide Medicaid reimbursement, you know, for doula that we do, but know that it's all of these things working together because that's who then sits in the work group. Sure. That's who then will do that report that then becomes legislation. And so I wanted to add that, and I have to give you the bill number that Solange said. So ready, write this down. It's Senate Bill 5517A. Did you write that? Assembly Bill 23. Oh, it's in the materials.
And
great.
It is in the materials.
So there you have the bill number for the C-section review.
And I just want to just highlight one thing before we end. There's another piece of legislation that needs to be done, and it's paid medical leave. So in New York State, we have paid family leave, so that if you want to take care of a baby or if your loved one passed, you can spend time with them. But if you're sick, or if you have pregnancy complications, or if you have a stillbirth, there's no benefit for you. There's no job protection if you want to just take a break, as we were talking about. And in New York State, it failed to get into the budget. We had a deal. It fell apart last minute. It failed to be done at the end of session. We couldn't get a deal because they said it was too expensive for us, you know, as New York State, which is, I think it's a farce. And so we need your political help to get it done next session because there are many women who have to go back to work, as we said, right after pregnancy, or who have a stillbirth and have pregnancy complications, and they can't take off for themselves. They need people who need cancer treatment, people on dialysis, they can't take off. Wow. And so we need to have an initiative here in New York State, paid medical leave or temporary disability insurance, so that we could take off and also have job protection. So I felt that we needed to talk about that before we left.
Very compelling. No, and the good news is I am now going to open this up to all of your burning questions. So there are going to be staff from NYU McSilver walking around with microphones. So please raise your hands. So much comprehensive knowledge from either panel. So you will have access to both panel 1 and panel 2. And I'm going to turn this over to the Honorable Rose. Go ahead, take it away.
Thank you, thank you. So first and foremost, a big round of applause for our legislators. I am so in awe of all of you. You are the dream team. And I know that your careers and futures are very bright, and we are the great beneficiaries of that. And I have an idea. This should be a podcast. And we should have you guys, incorporate doulas, midwives, our leaders in government, and package this, because all I keep thinking all day is for us, by us, right? And so that's my idea. Take my call when I call you. And again, thank you so much, and congratulations, Natifa. Thank you so much for being here, bringing your beautiful baby. And to our senators who traveled from I know Long Island is far, but to our senators that came from really upstate New York to be here today, I love all of you. Okay, let's do question and answer.
Okay.
Hi, good morning. My name is Patricia Loftman. I've been a midwife for 43 years, over 2,500 births. And I wanted to make just two comments. One for Dr. Williams, who did a marvelous presentation on mental health. I think the problem that we tend not to recognize is that we don't have sufficient mental health clinicians. That's number one. But not only do we not have sufficient mental health clinicians, we don't have mental health clinicians of color. Black and brown people will not go to a mental health clinician who is not a mental health clinician of color, even when they know they need help, even when they know that they need care. So I think one of the things that we find from a policy standpoint is that we really need to have programs that can train mental health clinicians of color so the capacity is there. At the current time, it does not exist. But I also want to take a minute to kind of preempt my midwifery colleague over here and speak to, I think Dr. McCullough had said a lot of the women don't return for their postpartum care. And I think, you know, I have never had a patient not return for their postpartum care. And I think we have to acknowledge that Black women's health, Black women are not valued. And so when you have a clinician, you know, the relationship, as I teach midwifery students, the relationship is the most critical element in your care. You know, women understand when a clinician loves them. You gotta love Black women. And that comes across in every touch that you put on their body, the way you speak with them. And we don't have enough of that. So I'd like to thank everyone, especially our policy individuals, because you are the ones who provide the guidance for us in terms of what we do, you then translate into, you know, critical care.
Okay, I want to make sure that we get everybody in, so please be succinct. We also have our clinicians that are here today and our researchers that are still with us, so if you have a question for them. Yes.
Greetings and salutations, everyone. Helena Grant, President of New York Midwives and the co-chair of the Maternal Mortality Review Committee. So in the midwifery community, we call that woman over there Mother Pat. She is a midwifery mentor and a legacy in New York State. So just to piggyback off of what she said, we also need to understand that when you look at the map in New York City especially, and in New York State, we do have a plethora of psychiatric and psychological and behavioral health providers. But if you were to just press a button, you would see that most of them do not take Medicaid or other insurances. So we do need to do some workforce development and develop a pipeline for people to not only have culturally concordant care, but to not just practice with Black and brown people for 3 to 5 years when they can pay their loans and then leave the communities that they learn on and go serve other communities. The other thing I also wanted to get very clear on about the commentary about Black women not going to postpartum. If birth is traumatizing to you, and during your prenatal care, every time you see a different person, and during your birth, different people are in your vagina, and we should be able to use that word in this room, then why are you coming back to again possibly be traumatized at a postpartum appointment? So in these discussions, it is deeply important that we not just look at what is happening, but we unpack the why of what is happening. People are responding to what is happening to them. It's not just, you know, a blanket thing where, you know, these statistics are what they are. There is a why that needs to be unpacked that is culturated in the behaviors that people learn within hospital systems. And until those hospital systems decide to put down the behaviors that uplift white supremacist structures, medical technocratic patriarchal models of medicine, and really start to infuse some of the things that we've talked about here today, it's really unfortunate, but we're not going to see the dent in the statistics that we would like.
Lenara, right behind you, the gentleman behind you.
Good morning. My name is Ryan Brown. I'm the founder and president of the Andreas Foundation, an organization that seeks to raise awareness about pregnancy and infant loss. My question is for the lawmakers here today, specifically around the connection point between maternal health and infant health. I keep hearing conversations people have about how outcomes are tied to the amount of care that's given to the mothers while they are pregnant. But what happens when you have the right care and then you still have a negative outcome? What are we doing from a law standpoint to help support those families that are impacted not by stillbirth, not by preterm loss, but from carrying a child 41 weeks and then losing it within 24 hours?
Currently, on the governor's desk is a law. It's called the Grieving Families Act, which amends the wrongful death statute in New York State. We're currently, if a loved one dies and they're not the breadwinner of the family, your legal liability or the amount that you can sue, or if you can sue, is very low in New York State. A baby is not considered a breadwinner, so you really can't sue an institution. And so we want to change the law. So we've passed the Grieving Families Act several times to give parents a legal ability to sue the hospital if their baby were to pass away. And we do this because sometimes, we can't legislate good outcomes, but we can give recourse to those so that the hospitals know that if they do bad by us, they're going to get sued. And so that's one avenue that we're advocating for. It's not the ideal. I wish I had a better answer for you, but at least it's an avenue and a pathway for people to be able to get some recourse. And many of these hospital industries, the only thing they understand is money. And so they understand that if they get sued, they're going to be more cautious. They're going to do more tests. They're going to make sure that they are operating in a better sense, because now every person's life is valued in the eyes of the law.
Thank you for that clarification. I also want to add in that what I have experienced is that doctors will put into their notes that you refuse care when something goes wrong, despite the patient not actually refusing care. So maybe put into place a policy that blocks them from saying that you refuse care without you actually signing off on some of those things.
And I agree. That's maybe something we could work on.
Yeah, I was going to say, just to add on to that, I think there are pieces, as we spoke about access to information and just how we navigate systems. It is important that people know their rights. And even though you can have all of this down pack and have literally a birth plan, and unfortunately there are outcomes, as it was mentioned, we just aren't in control of. But it is important that we're asking people to put things in our notes, right? So as you're speaking to your doctor and whatever the case may be, and you may feel, put this in my note, please. Who's taking notes? Make sure this goes into my notes. And I would love the physicians to speak to this a little bit more, because this is a way to stay on the preventative side if something does happen. And a lot of times, we don't know, even outside of the maternal health care space, we don't know to ask our physicians to put things into their notes that we are saying to them, because they are refusing the care or going back and forth with us on the type of care that we're asking for, or even addressing the issues that we're having in its totality. So I'll pass it over to you guys.
So actually, I no longer do clinical medicine anymore since being at the Department of Health for the last 2 years. However, what I did want to mention, and that goes to the MMRC report that I noted when I spoke with you all, one of our recommendations is talking about how notes are taken by clinicians and what wording needs to be eliminated and how we should go about eliminating it. So once again, this report that comes from all of the maternal deaths that occur in New York City, the committee was able to see that some of the note-taking was of concern. So we are, once again, trying to address these issues and put into practice ways that will help eliminate maternal mortality and infant mortality in New York City. Now, I don't know if you want to speak to the note-taking?
Sure. So, well, I'm a high-risk obstetrician by trade. I'm a maternal fetal medicine specialist, and I see patients in all areas of their care. And this is a partnership, okay? The doctor, the patient, you know, we both have vested interest in the good outcome of the pregnancy. I'll give you just a case scenario. I saw a patient roughly about 2 weeks ago. 5 years ago, she had a ruptured uterus during her pregnancy at 7 months. She came back for prenatal care, and at just about 7 months, on ultrasound, you can actually see a rent in her uterus with membranes protruding out. So we advise her do a cesarean section immediately, you know, for your safety, for the baby's safety. She had no clue. She was not having pain or anything like that. She showed up again a couple of weeks ago pregnant, and the conversation that we had was, this is very dangerous. This is not only dangerous for the pregnancy, but also for your health. And we had a detailed conversation, and part of that conversation was about pregnancy termination because of the impact, the potential impact of this on health. And that was a personal decision of hers to make that decision. That was my decision. I gave her all the options that there are and what the potential risks are. And something like that should be part of that documentation. As I said, it's a partnership. You know, our patients, especially if you're on certain EMR, you have access to your medical record. You know, you can get in and you can recommend ask your physician, you need to change this. If there's something there that's derogatory or that you don't agree to, you have that option. So, and we as professionals need to be, you know, responsible for documenting accurately. There are consequences of documenting incorrectly. And that's what we try to teach our residents or fellows or younger physician in training. It's extremely important. So don't forget, it's a partnership with patient, with doctor, with nurses, with midwives. We're all part of that team for the best outcome for both mom and baby.
We've got to close out. I'm sorry, we have to close out. We went long before NYU comes and charges me again for the room. So we're going to leave it with you, Dr. James Contarelli.
So I want to highlight some of the things that was said before. Number one, in choosing your provider and interviewing your provider, feeling comfortable with your provider, knowing who your provider is, their philosophy of care, and how they're going to care for you. Understanding the community that you are coming from, who's with you. Are you able to have a doula? Do you want a midwife as part of your team? And then understanding what Dr. McCullough said, it is a partnership, we're all involved. I encourage everyone, if they do have access to their electronic medical record, to please access it. And I will state, as a current clinician, one of the things that I see with my own patients of color, black and brown, is that we have access to our electronic medical record. We won't go access that, but we'll go on Facebook. And you won't look at your own record, or you won't ask me for your record. So one of the things as an educator that I do is to educate my students that you are responsible for what goes into that patient's chart. You're part of a team. And if I pick up the chart after you, because we don't work 24/7, I should understand explicitly my patient's desires, my patient's intentions, who's a part of their care team, and what the plan was that was discussed. If there's a birth plan, it should be in the chart. So I would say to everyone, know your clinician, know what you want, understand who's in your healthcare team, understand it's a partnership. Please access your electronic medical record. If there's anything you want us to put in the chart, we have a right, we have to. It's your chart, not mine, yours. We're here to serve you. As medical professionals, we're service providers.
All right, ladies and gentlemen, I know we've had a very rich conversation, and thank you so much to all of you in the audience for being here. Just want to do some very quick thank yous. First and foremost, to our incredible moderator, Ebony K. Williams. Thank you so much. To our panelists of health experts and to our legislators, thank you so much. We are so much better because of your leadership. I want to thank all of the partners, the sponsors. I want to thank our ASL interpreters for being here. Thank you, thank you. I want to thank especially the mayor's office, Natifa, Commissioner, Ashley. Thank you so much for your guidance, your thoughts, letting me know to mark how old my womb is, which I didn't know about, which I think about all the time. But this is information. I've learned so much today. So thank you so much to the Mayor's Office, Commission on Gender Equity, NYC, Her Future, the Office of Equity and Racial Justice. Thank you so much. We're so lucky that you are where you are today, and all the people from City Hall that are here. I want to thank the team at McSilver, particularly our communications team. We have been up very early. All of you who wanted to get your friend in at the last minute, even though registration's been closed for a week and a half. It was a very early morning for all of us, but we love you. You know, we love you. So I want to thank Colby, Miles, Amu, Frederica, all the volunteers from McSilver that are here today, NYU Government Affairs. When we couldn't reach the electeds, some of you have your cell phones, I know how to get to you, but for the electeds that we could not reach, thank you, Elvin Garcia, who's our Director of Government Affairs. Thank you very much. I want to mention something very exciting. Later on today, together with Dr. Natasha Williams and NYU Langone Health's Institute for Excellence in Health Equity, we will be announcing a research fellowship that we're doing a search for, and a primary focus of that fellowship in research, because remember, the academic partnership with legislators, the community, I always say that. Think of NYU as a partner. Think of CUNY as a partner. We will be launching that fellowship that will have a primary focus on Black maternal health. So be on the lookout for that. I'm very excited, very proud. Thank you, Dr. Williams. Also, we have an exit survey. We want to hear from you about your experience today and your feedback. And the last thing, Ebony K. Williams, if you'll come forward, please. So Ebony, who, when she was about to give birth and we were talking about doing this event, I said, we're thinking about doing this legislative panel. I'm concerned that you won't be there because you know, it'll be like a month and a half since you had a baby. She's like, I will be there. So thank you. Thank you. Oh, thank you so much, everybody. Have a wonderful rest of the week.